Welcome to the deep dive. Usually when you get a medical diagnosis, there's this expectation of like clinical precision.
Oh, absolutely, like a broken bone.
Right. You break your arm, the x-ray shows that jagged white line,
Mhm.
and the doctor just points at the screen and says, there it is. That's the problem.
It's very black and white.
It is. And it's incredibly comforting to have things be visible and neatly categorized like that.
Mhm.
But then you step into the world of women's health, specifically pelvic floor function, and suddenly that x-ray machine is just useless.
Completely useless.
Yeah, we are looking at a diagnostic landscape that is, honestly, it's pretty murky.
It is the definition of diagnostic muddy waters. I mean, you are dealing with a part of the body where symptoms change from day to day and, well, sometimes even hour to hour.
Wow, really? Hour to hour.
Oh, for sure. A patient might feel, completely unsupported and in pain on a Tuesday and perfectly fine by Friday.
Which is incredibly frustrating if you're the one experiencing it.
Ex
So we have gathered a really fascinating stack of sources for you today. We've got medical clinic blogs, physical therapy guidelines, peer-reviewed research papers, and we're going to explore a question that might, honestly, fundamentally change how you understand your own body.
And it's a big question.
It is. We are asking, can tracking your menstrual cycle actually help identify temporary pelvic floor laxity symptoms?
Right, because we're going to decode the surprising hormonal fluctuations that dictate your pelvic floor strength.
The mission here is to help you figure out whether that sudden feeling of like looseness or heaviness, or maybe even a tiny leak when you sneeze.
Which is so common, by the way.
Right. Whether that's just a temporary cycle-related dip or an indicator of persistent pelvic floor dysfunction.
Okay, let's unpack this, because before we can track anything, we have to understand the machinery we are working with.
Yeah, the pelvic floor isn't just a static shelf holding everything up. It is a highly dynamic network of muscles, ligaments, connective tissues.
Think of it as a living, breathing hammock resting at the very base of the pelvis. And its job is incredibly demanding.
I mean, it has to physically support the bladder, the bowel, the uterus.
Right, and it controls urinary and bowel continence, so it's constantly regulating pressure. Plus, it plays a massive role in sexual and reproductive function.
All while you stand, while you walk, while you lift heavy boxes.
Yeah, it basically functions as an active shock absorber.
But here's the critical part from our sources. This shock-absorbing hammock is entirely at the mercy of your endocrine system.
Yes. The vagina, the vulva, the urinary tract, and the pelvic floor muscles themselves, they are packed with hormone receptor cells.
So they're constantly listening to the chemical signals in your blood.
Exactly. And estrogen, well, estrogen gets most of the spotlight here.
Biologically, what does it actually do?
So estrogen is responsible for increasing the integrity, the thickness, and the elasticity of soft tissues like muscles and fascia.
It keeps things plump, right?
Right. It promotes blood flow and keeps tissues resilient.
So if we think about the connective tissue in the pelvic floor like a rubber band.
I love this analogy.
Yeah, when estrogen is high, that rubber band is like brand new out of the box.
Yeah.
It's snappy, it's strong, it holds tension perfectly. You stretch it, and it bounces right back.
But when estrogen levels drop...
It's like that rubber band has been stretched out and left in the hot sun. It feels a bit loose, a bit slower to respond. It loses that snappy recoil.
And that physiological chain reaction happens fast. Decreased estrogen literally means thinner tissues, reduced blood flow, and a loss of that crucial elasticity.
The cellular scaffolding just isn't as robust.
Exactly. But estrogen isn't working alone to maintain that hammock.
Right. And this brings up one of the most surprising facts from our research.
Oh, the testosterone thing.
Yes. When we hear the word testosterone, we immediately associate it with men and male reproductive health. But the sources highlight that women actually produce more testosterone than they do estrogen.
Wait, really? More?
Yeah. It's heavily overlooked in conversations about female health. Testosterone is produced in the ovaries and the adrenal glands, and it is a biological requirement for maintaining muscle mass.
Ah, okay. So while estrogen provides the elastic scaffolding, the snappy rubber band testosterone works directly on the muscle fibers themselves.
Exactly. It binds to androgen receptors in the pelvic floor muscles and commands the cells to synthesize protein.
Which builds thicker, stronger muscle fibers.
Right. So if you want a strong pelvic floor, you need adequate testosterone to maintain the actual bulk of the muscle.
What's fascinating here is that we essentially have this trio of hormones, estrogen, progesterone, and testosterone constantly pulling levers behind the scenes.
And because these hormones are never static for women of reproductive age, The tension on our internal rubber band is just constantly changing,
It creates a schedule of physiological shape shifting.
which sounds exhausting.
It is. And if you don't understand the timeline of those shifts, the resulting symptoms can feel incredibly alarming.
So let's walk through that schedule week by week. Let's start at the beginning of the menstrual cycle, the period itself, days 1 through 7.
Okay, so during the menstrual phase, your estrogen and progesterone levels plummet to their absolute lowest point in the cycle.
And because estrogen provides that snappy elasticity, this sudden hormonal vacuum causes literal muscle laxity.
Right. The tissues are chemically deprived of their support system, so the muscles become weaker and they fatigue much faster.
Plus, the uterus is actively shedding its lining. So you have swelling, inflammation, cramping.
Yeah, not only is the pelvic floor hammock at its absolute weakest, but it's suddenly being forced to support a heavier, inflamed organ.
The sources note this combination creates a very recognizable symptom, a distinct heaviness or a dragging sensation right in the pelvis.
And women who already have baseline pelvic floor dysfunction often find their symptoms aggressively peak during these days.
Like increased pain sensitivity.
Yeah, and a higher risk of urine leakage.
Okay, hold on. Let's look at this practically. If I'm on day 3 of my cycle and I feel a sudden dragging sensation or, I sneeze and leak a little bit of urine,
Yeah.
my first instinct isn't going to be, oh, it's just my hormones.
Hmm.
My first instinct is going to be sheer panic that my pelvic floor is broken.
Which is a completely understandable reaction and precisely why context is everything here.
Right.
If this is happening specifically on day 3 of your cycle, a leak or a heavy sensation doesn't necessarily mean your pelvic floor is failing structurally.
It's a state of temporary laxity.
Exactly. It is a biological response to a massive hormonal dip combined with uterine inflammation.
So as that inflammation settles down and as your hormones begin to climb again in the following week, the muscles usually return to their normal resting tone.
Right. So we move out of the period into the follicular and ovulation phases, roughly days 7 to 14.
The ovary starts secreting estrogen again to develop a new egg and thicken the uterine lining.
And as estrogen climbs, the pelvic floor gets its snapback. The muscles become stronger, more responsive, more elastic.
So by the time you hit ovulation around day 14, estrogen spikes dramatically.
Yes. And alongside that spike, there is a massive surge of increased blood flow to the entire pelvic region.
Wait, if estrogen makes the muscles strong and snappy, wouldn't a massive spike at ovulation make you feel like a superhero?
You'd think so, right?
Yeah. Why do the sources say this phase can cause weird symptoms?
Because, well, there's such a thing as too much localized congestion. The sudden rush of blood flow and the peaking estrogen can cause the pelvic floor to feel hypersensitive or even a bit tense.
Oh, interesting. So some women experience a profound awareness of their pelvic organs.
Yeah, you might even feel a brief sharp pain known as Mittelschmerz as the egg is physically released from the ovary.
And it can sometimes manifest as a heavy sensation.
It can, but mechanically it's completely different from the period heaviness. There's no swelling or bleeding pulling the hammock down. It's simply vascular congestion that only lasts a day or two.
Okay, so then the egg is released and we enter the luteal phase, days 15 to 28. Estrogen takes a backseat.
And progesterone takes the wheel to prepare the body for a potential pregnancy.
If estrogen is the snappy rubber band, the sources say to think of progesterone as a warm heating pad.
That's a great way to look at it. Its primary job is to act as a smooth muscle relaxant. It wants to keep the uterus completely calm and still so an embryo can implant without being disturbed by contractions.
But that chemical heating pad effect doesn't just stay neatly inside the uterus, does it?
No, it bathes the whole pelvic region. It chemically signals the pelvic floor muscles to relax, which can make them feel weaker or less supportive.
And it acts on the digestive tract, too.
Oh, yeah. It slows down digestion significantly, which leads to increased bowel gas, constipation, and water retention.
So it's a cruel irony. You feel mechanically loose from the progesterone, but you feel incredibly tight and uncomfortable from the severe bloating at the exact same time.
And the body tries to manage that contradiction. When the pelvic floor muscles feel strained by the physical downward pressure of a bloated, heavy bowel,
Right.
and they are simultaneously being chemically told to relax by progesterone, they often overcompensate.
Oh, they try to grip defensively to hold everything in place.
Yeah, actually. And that defensive gripping leads to a feeling of intense tightness or even muscle spasms.
So over the course of 28 days, your pelvic floor goes from weak and heavy to strong and snappy to tense and congested to bloated, chemically relaxed, and spasming.
It's a roller coaster.
It really is. But here is the critical pivot for us.
Yeah.
How can you tell the difference between these monthly hormonal fluctuations, which are totally normal, and an actual clinical issue that requires medical intervention?
Well, to figure that out, we first have to define what true clinical laxity actually is.
The sources define vaginal laxity, or VL, as the subjective feeling of looseness or reduced physical support in the vaginal canal and at the entrance.
It's often associated with a wide vagina, reduced physical sensation during intimacy, and sometimes physical symptoms like air trapping.
Or vaginal wind, where air enters the vagina during movement and is audibly expelled.
Right. And unlike the temporary laxity of a menstrual cycle, true VL has long-term structural root causes.
The most common cause by far is trauma from childbirth.
Yeah, a vaginal delivery can severely overstretch the tissues and cause macro or micro trauma to the levator ani muscle.
Let's clarify that. What exactly is the levator ani?
It is the thickest, most substantial part of that pelvic floor hammock. It's the primary lifting muscle.
Okay, so when the levator ani is torn or overstretched during delivery, it loses its ability to hoist everything up.
Exactly. And that trauma often leads to a permanent widening of something called the genital hiatus.
Visually, the genital hiatus is essentially the U-shaped opening at the bottom of the pelvic floor sling where the urethra and vagina pass through.
Right. So when the muscles around it experience trauma, that U physically stretches out and becomes wider, which is why things structurally feel loose or unsupported.
The other major long-term cause of laxity is aging and menopause.
Yes. During menopause, estrogen doesn't just dip for a few days, it permanently drops.
This leads to a condition called genitourinary syndrome of menopause, or GSM.
And this happens on a cellular level. Without estrogen, the fibroblasts, which are basically microscopic factories inside your tissue that churn out collagen, they just shut down.
The factories literally board up their windows.
Yeah, the connective tissue fibers fuse together, and the mucosal lining, the delicate tissue inside the vagina, thins out drastically.
It goes from being thick and robust to resembling like deflated bubble wrap.
It permanently loses its elasticity and structural volume.
So what does this all mean? It means we have a massive overlap in symptoms.
We really do.
The symptoms of clinical laxity or even pelvic organ prolapse, where an organ like the bladder literally drops down and bulges into the vaginal canal, cause a heavy, dragging sensation.
And that feels mechanically identical to the heavy, dragging sensation of a day 3 menstrual hormonal dip.
This raises an important question. How do clinicians actually separate the two? If the symptoms feel exactly the same to the patient, how do we get an objective diagnosis?
Well, the research shows it's a mix of objective tests and subjective experience. If you go to a physical therapist or a doctor, they might do a physical exam using the POPQ system.
POPQ, that stands for pelvic organ prolapse quantification, right?
That's the one. It's essentially like a surveyor's map of the vagina. The clinician uses a grid system to measure specific points to see exactly how far tissues have dropped relative to a baseline.
They might also test your muscle strength using the modified Oxford scale.
Right, which is a very straightforward manual test. The clinician asks the patient to grip or contract their pelvic floor muscles around the clinician's fingers.
And they grade that strength manually from 0, which means absolutely nil, no flicker of movement at all, up to 5.
And 5 represents a strong, powerful contraction that pulls inward and upward.
So if a doctor's exam using the POPQ or the Oxford scale only captures a 10-minute snapshot of a 28-day shifting cycle, how do we capture the rest of the movie?
That is the million-dollar question. Before you ever step foot in a clinic, the physiotherapy guidelines suggest we become our own data collectors.
Because vaginal laxity is diagnosed primarily based on self-reporting.
Exactly. The strategy, which is highly recommended by health authorities, like My Health Alberta, is the menstrual and bladder diary.
So the concept is to map your physical pelvic symptoms directly against the timeline of your menstrual cycle.
Yeah.
I know what you're thinking. Tracking every sneeze, every weird twinge, every glass of water for 2 full months sounds exhausting.
It is a chore, I won't lie.
But here is why the payoff is worth that daily annoyance. It reveals causality.
To execute this, you need to record your symptoms for at least 2 consecutive menstrual cycles. 1 month just isn't enough to see a definitive pattern.
Right, you track the precise dates of your period bleeding, and if you're able to track it, your ovulation window.
And alongside those dates, you log your symptoms every single day.
Like, are you feeling heaviness, looseness, bloating, urinary urgency, a dragging sensation?
And you don't just check a yes or no box. You rate the severity as mild, moderate, or severe.
And if you are already seeing a pelvic health physiotherapist, they will usually ask you to add a 3-day bladder diary into the mix.
Yeah, this is a highly specific 72-hour window where you track your fluid intake, exactly how often you go to the bathroom, and the specific circumstances of any leakages.
Like, did you leak when you coughed? When you heard running water?
You do this to separate the signal from the noise. If you look back at 2 months of diary entries and you see that feelings of laxity, weakness, or heaviness occur only during the low hormone days of your period.
Or maybe during the severe bloating of the luteal phase?
Right, and then they completely stop and return to normal during the rest of the month.
Yeah.
You can take a deep breath.
If the symptoms resolve when the hormones shift, you have identified a normal physiological fluctuation.
It's the rubber band temporarily losing its snap due to its environment, not because the band itself is broken.
But if that diary reveals that the feeling of looseness, the little leaks, or that dragging sensation persists entirely throughout the 28-day cycle,
Like if it's there on day 3, but it's also there on day 14 when your estrogen is peaking, and it's still there on day 22.
then you have identified a baseline pelvic floor dysfunction.
Yeah, that data proves it's not just a hormonal shapeshift. It indicates a structural weakness.
It could be the widened genital hiatus from childbirth trauma or early perimenopausal collagen loss.
And that persistent baseline weakness is what requires clinical intervention, whether that's specialized physical therapy, fitting a silicone pessary for internal support, or discussing medical options.
Tracking your cycle doesn't just give you diagnostic data, though. It actually gives you an operational manual for how and when to treat your body.
The sources give some incredibly actionable advice based on these phases.
You can basically cycle sync your pelvic floor rehab.
Yes. During the follicular phase, days 7 to 14, your estrogen is high. Your internal scaffolding is snappy, responsive, and bathed in great blood flow.
This is the absolute perfect time to do Kegel exercises, build core strength, and do heavier resistance training.
Your body is biologically primed to build muscle and handle intra-abdominal pressure.
Conversely, during the luteal phase, or the menstrual phase, when your muscles are physically fatigued from low estrogen, chemically relaxed by progesterone, or cramping from shedding the uterine lining.
Yeah, that is not the time to push for a personal best in heavy deadlifts.
Pushing a weakened, inflamed pelvic floor with high-impact exercise can actually cause strain or trigger leaks.
So during these lower hormone phases, the focus should shift entirely to low-impact activities.
Walking, swimming, restorative yoga, deep diaphragmatic breathing.
And specific pelvic floor relaxation techniques. You want to release the defensive tension, not build more of it.
Here's where it gets really interesting. By taking 5 minutes a day to simply pay attention to the calendar and jot down a symptom, you completely transform your role in your own healthcare.
You really do. You stop being an anxious patient who is guessing about whether something is fundamentally broken.
You become an empowered self-advocate.
Imagine walking into a physiotherapist or a doctor's office and handing them 2 months of mapped data.
You bypass months of guesswork and expensive trial and error.
You give them the exact blueprint of how your body functions over time.
It's an incredible shift in perspective. To recap our deep dive today, we tend to think of our muscles as static machinery, but the pelvic floor is a highly dynamic structure.
It is entirely dependent on the continuous chaotic ebb and flow of estrogen, progesterone, and testosterone.
Which means your symptoms will ebb and flow too.
Tracking your cycle isn't just about knowing what day your period starts or when you might be fertile. It is a vital, free, completely non-invasive diagnostic tool.
It is the most effective way to differentiate between a temporary, harmless hormonal laxity and a persistent structural weakness that needs clinical support.
But knowledge like this is only really valuable when you apply it.
Absolutely. By keeping a simple symptom diary for just 2 months, you can fundamentally change the conversation you have with your healthcare provider.
You ensure you get the exact right support, whether that means targeted physical therapy to rebuild the levator ani, trying a support pessary, or sometimes just getting the medical reassurance that your body is doing exactly what it's biologically programmed to do.
It takes the fear out of the equation.
You map the terrain, you understand the mechanisms, and suddenly the diagnostic muddy waters aren't quite so murky anymore.
I love that. And it leaves me with one final lingering thought for you to mull over.
Okay, let's hear it.
We've spent this time focused strictly on the pelvic floor. But if this vital network of muscles, the very foundation of our physical core, fluctuates so predictably and so dramatically every single month based on hormones, how much of our broader physical performance, our daily moods, or our random aches and pains are we currently completely misunderstanding simply because we aren't tracking our internal hormonal weather?
Oh, wow. It certainly makes you wonder what other patterns are hiding in plain sight, just waiting for a calendar and a pen.
It really does. Because when it comes to understanding the human body, maybe we don't always need an X-ray to see the truth. Sometimes we just need the patience to look for the pattern.